So this talks about core stability and trunk strengthening, in particular with people with low back pain. So the muscles of the lumbar spine include the iliocostalis lumborum, longissimus thoracis, quadratus lumborum, multifidi, and psoas muscles. And recently, there's been some excellent MRI studies of changes in exercise in people with low back pain using MRI. We can see they essentially take cuts, cross sections, perpendicular to kind of the bone alignment here. We can see the strategies here, and then they get cuts that look like this. And you can do the circumference of different muscles and muscle groups. So here we have the iliopsoas, just lateral to the lumbar vertebrae. You see the lumbar vertebrae here. Here's the spinal canal with the cauda equina and the exiting nerve roots, the transverse process, and then just lateral to this transverse process, we have the quadratus lumborum. Then with the erector spinae group, which in the lumbar region primarily includes the iliocostalis lumborum, which would be more lateral, so it'd be lateral in this muscle bunch, and then kind of medial in the muscle bunch would be the longissimus thoracis, and then right here, right next to the spinous process of the vertebrae, we would have the multifidi muscles. And so you can get the circumference of the muscles using MRI, and that gives you some information about hypertrophy and atrophy. We're going to use this study to understand forward bending for the body. So what they did in this study is have people forward bend. Here, see the position here on the left, before and after performing this stretch. And you can see the stretch, they have the people hold it here in 10 minutes of flexion. We have the angle patterns here and the EMG above. And what we notice is that essentially before and after the stretch, you can see here's flexion, then they kind of rest. They spent a few seconds here in flexion, and then they return to upright. And we can really see that essentially they increase their motion after the stretch and significantly. But the EMG was relatively similar, essentially, indicating that the EMG really controls this lowering part, but once they get into full flexion, the loads on the back are balanced by the passive elements of the trunk, and then when they come back to upright, the active contractile component of the muscle is recruited again, and we can see that here in the EMG. So what this is telling us is this mechanism where the load is the highest is well handled by the passive elements of the muscle. So in this study, the flexion relaxation phenomenon, that there's tendency for the back muscles to relax when someone's forward bent like this, is being studied relative to low back pain. And what we can see here is here's the same kind of data where we have angled data on the below and EMG above, and we can see the flexion occurring, and then they're basically holding for a second, and then again going back into extension, and then repeating that cycle. And then here's a control participant in this particular study, and you can see the EMG bursts associated with the transition periods, and then the silence of the EMG or relatively low EMG when they're flexed, and that's repeatable. And here's a person with low back pain performing the same types of movements. We can see here is when we would expect the muscles to be turned off when they're kind of plateaued in that flexion position. And instead what we see is a lot of activity in the rector spinae muscles. So one potential hallmark of low back pain is the failure to restore the flexion relaxation phenomenon. So a normal goal for therapy might be to restore this normal activation of the muscles. So let's take a look now why the erector spinae muscles may take advantage of the flexion relaxation phenomenon by holding the forward bending position with a stretch, and the importance of deep and superficial muscles of the spine during the transition period when we're coming out of forward bending and back to upright. So first, we'll start with anatomy, and we have the medial lateral axis for a motion segment drawn in here through the vertebral body, and then the muscles in this space
between the spinous process and the transverse process. And we have iliocostalis lumborum lateral, the longissimus thoracis, and then the multifidi muscle, and then the aponeurosis of the erector spinae superficially. And we can see significant stretch would be in these muscles as we forward bend, and that would recruit the parallelistic element. So why might we need them to increase or enhance their force capacity by taking advantage of the parallelistic or the stretch component of the muscle? So essentially, if we look at their moment arms, the erector spinae aponeurosis is quite much, it's significantly longer, for example, than the other kind of spine muscles. And then if we look at it from a sagittal view, we can kind of see how the erector spinae aponeurosis sits posterior, right? And so we can also see that when we kind of stretch or flex the spine, that the intersegmental stability that we might need to kind of keep each vertebrae in place is taken advantage of by all of the ligaments being taut. And so essentially when the spine's fully flexed, there's a lot of tension for sure in the posterior elements of the discs and ligaments and the passive elements of all the muscles. But we can take advantage of that essentially by then rotating our pelvis posteriorly and taking advantage of our glute maximus and hamstring muscles to kind of lift the load. And that's, the basic mechanism of how our bodies are designed. Now, during the transition from forward bending to upright, once we hit a certain point, we want to come out of that flex position and move into this extended position. So in order to do that, it's important to have both superficial and deep muscles contracting. And the reason is that the long extensors of the back, the iliocostalis and longissimus thoracis, span several segments. And the tendency is when they contract to bend at some random point throughout the spine. And so in order to make the spine move more symmetrically and in unison, we need these intersegmental muscles that only span one or two segments. And that's really represented by the multifidi muscles. And the other piece of it is the multifidi muscles also, they look small in this picture. They have a high pennation angle, and that high pennation angle gives them a very large physiologic cross-sectional area and makes them capable of developing high amounts of force in the spine to control intersegmental motion. And so during the transitions from standing to forward bending and from forward bending to upright, it's important that we have both these long muscles that have great power and torque, and then these smaller muscles that are intersegmental to control spine motion. So this slide really kind of tries to emphasize the fact that we need both the flexion relaxation phenomenon, or the stretch of the muscles, the passive element that's part of creating muscle force, and we need this combination, this synergy of co-contraction between the superficial and deep muscles during transitions from forward bending to upright, and vice versa. In 2000, Hyde et al. Noticed in a study of low back pain patients fairly soon after their injuries that the multifidi muscle were demonstrating atrophy. And that really started a whole series of studies on the multifidi and what their physiologic cross-sectional areas are and look like in patients with low back pain. And it caused a lot of enthusiasm for the idea that the lack of stability associated with atrophy of these muscles might be contributing to low back pain, and then might be remediated with exercise. And we see the interest in that is continuing with newer muscles here, newer studies here in 2014 by Hyde, and then Paul Hodges in 2013. And to some extent, the size of these muscles has been linked to injury in Australian footballers, and then has been a focus of study in ballet dancers. Clinically, we don't usually have access to MRI and PCSA, especially before and after treatment. And so a test to determine if muscle control is important to pain, and with the idea being that muscle control might stabilize and prevent pain, are these two clinical tests. We kind of see here what's happening is the clinical test is the person pushes down on the lumbar vertebrae and provoking pain, if that's true, and then they have the people activate their lumbar muscles by extending the legs, and if that then relieves pain while the therapist maintains pressure, that's a sign that the muscles basically are moving the vertebrae or controlling movement of the vertebrae and preventing pain. And so better muscle control might be hypothesized than to help that person control their pain. And in this particular situation, the situation is slightly different, where you have the person push down, it causes pain, then you have the person extend the spine, engaging the facet joints and preventing forward mobility of that particular segment, and then you push down again, and if there's no pain, well, then this is suggestive that better stability might help relieve the pain that could maybe achieved through muscle control. And so these are two kind of indicators that some type of training, especially related to intersegmental control, might help a patient. So here's some exercises that are typically given for stabilization of the spine, and we can see the planks here, where we have the abdominals as the target here, and the forward plank, the extensors, and the bridge type of kind of plank exercise, and then the side benders, which include both abdominal and extensors in this kind of side bending plank. So the important thing about these planks, they're really popular and they're commonly given, is what muscles they activate, and secondly is that they only achieve very low levels of co-contraction during the side plank, and then they're really it's only synergist, so there's really no co-contraction during the abdominal forward plank or the extensor backward plank, and that's backed up by this study in JOSPT in 2010. And so in conclusion, when you look not just at this study, but many studies that look at these kind of plank exercises, that the EMG, the activation is clearly there in terms of isolating these different muscle groups, but the amplitudes suggest that the percent MVC is very low, suggesting that most patients will not experience hypertrophy as a result of doing these exercises.
And just to kind of back that up, we have a 2001 paper by Daniels et al. In the British Journal of Sports Medicine, where they looked at stabilization exercise and noted that their intensities were fairly low, and essentially that there was no muscle hypertrophy in the multifidi using CT scan after a 10-week program and those exercises. And so it's quite clear, essentially in this paper that stabilization exercises alone won't hypertrophy these muscles. However, stabilization exercise combined with progressive resistive exercise of trunk extension, 1 rep max, 70%, 3 sets of 15 reps, resulted in significant muscle hypertrophy of multifidi using CT scans. And essentially, the best exercise required a 5-second hold between the eccentric and concentric phase, so meaning, they were basically, the progressive resistant exercise was like over a Roman chair kind of thing, so they were horizontal, flexing, and extending, so that has a concentric raising component and an eccentric lowering component. And so the hypertrophy really occurred is when they required them to do a 5-second hold between the two phases. So to increase muscle mass, an intensive strengthening program is necessary in addition to stabilizing training. This is essentially backed up by a recent paper that's in press in 2018 and another paper in 2016 that show two things. One, it's clear that stabilization exercises have an effect on pain, but they really don't have an effect on hypertrophy in these muscles. after this strong data, what we really need to do clinically is try to restore the flexion relaxation phenomenon and make sure that the stabilizing muscles of the back are functioning well. And so there's two components of that. One is relaxation, and that's not addressed in this particular talk, but essentially also the mechanical loading has to be adequate to cause hypertrophy of the back muscles. And so this is a newer paper by Flanagan et al., which was done in post-lumbar surgery patients. And we can see here what they use is this kind of progressive Roman chair where they could gradually lower the person to being horizontal. So they would get kind of this Sorensen test position when they were fully perpendicular, horizontal with the ground for a load perpendicular to gravity. And essentially what they were finding is 1 or 2 minutes in this position to be able to isometrically hold was protective for low back pain non-recurrence. And so this is a good goal to hold for your lumbar patients who likely were suffering from some kind of weakness, and might be a good test for people who can tolerate it. And then how does this relate to pain catastrophizing and disability? This was a nice paper from Med Science and Sports Exercise 2014, where they looked at a control, which is no exercise. They looked at total body exercise, which included lumbar extension, which was a kind of Roman chair approach. They did seated rows, chest press, and a leg press, and then they compared that to lumbar extension only. And essentially, the results were significantly better for the total body exercise approach, where they looked at the Oswestry Disability Questionnaire, went from 29.4 to 18, Roland Morris 9.7 to 5, and pain catastrophizing lowered from 11.5 to 4.1, where the patients who only did the lumbar extension had non-significant results related to fear and the Tampa kinesiophobia scale. So this is a nice kind of summary to kind of if you want to hypertrophy the lumbar extension muscles, first you got to get them to relax, and then you have to load them significantly and likely integrate them with other exercises. Okay, what's new? In this case, partly what's new is old. What we saw in the studies is that we've kind of known some of these principles but didn't believe them. And so what I think it's time for in terms of thinking about low back pain is it's okay to restore normal forward bending to patients that have been injured. And what that means is that reinforcing the idea that their back is strong and that they can relax their back muscles when they forward bend and tap into that stretch component of the erector spinae muscles to load their spines. And what that also means is focusing on normal activation of back muscles. The second part is that if we want to hypertrophy the multifidi and other muscles of the back, we have to use appropriate loads, and that means progressive resistance training principles, which means that stabilization exercises aren't sufficiently high load to cause hypertrophy. So although they may have some minimal effects in terms of activation, they won't result in hypertrophy, and we need to move toward higher resistance training for people who need that kind of torque in their back to do their functional tasks. The last piece is that doing back training alone isn't sufficient really to address patients' fears and anxieties related to movement after having low back pain. So it's important to integrate your back muscle training with other kinds of functional movements that affect patients' cognitive worries related to back pain and forward bending. That's all for now.